perinatal care. I think most of you have been at these sessions before, so you're probably very skilled at using Zoom. Definitely want everyone to mute themselves, and you will be doing screen sharing, and so you'll be able to setting it on speaker view in Zoom will probably give you the best view of Jessica's slides and her as she goes. Let's see, Jessica's going to speak until about 12:40, 12:45, and then we'll have Q&A discussion for the last 15 or 20 minutes and wrap up right at 1 Pacific. And if you have questions, you are welcome to put them in the chat, or you can just hold them to ask her out loud when we get to the Q&A section. If you're interested in learning about upcoming research seminars at the Osher Center, there's a link here to get on the mailing list if you're not on it already. And I'll say this again at the end, but our next presentation is going to be at the end of February 27th. Yes, same time and place, and on a related topic with Liliana Lengua from University of Washington. So I'm just going to introduce Jessica a little bit more. Jessica Harrison is a sociologist and a mental health clinician specializing in feminist qualitative research methods to study the organization and politics of healthcare. Dr. Harrison's work spans the areas of reproductive, perinatal, and mental health. She's a postdoc research fellow, as I mentioned, at the UCSF Osher Center, and you'll hear more about her work today, and then she'll publish it in the future, and you can read about it. Go ahead.
Fingers crossed. All right. Thank you, Ariana. Hi, everybody. I'm going to share my screen. And then get us going here. Is that good? It's working? Okay,
great.
All right. Thank you for being here. I'm looking forward to sharing a little bit of my work on perinatal mental health integration in perinatal care. So let's dive in. I have a roadmap for us for today, the next 40 minutes or so. Let me hide this. Okay. I'm going to start out by giving a little bit of an overview of my background, my broader research aims. I've put this together in 4 parts. First, I'd like to talk about situating the whole person in context when it comes to perinatal health and mental health. The second part, I'm going to talk about how we're addressing perinatal mental health in the US. The third, we'll talk about this. I'll be drawing more specifically on my research findings here in part 3 as we look at the impact this has on clinicians and patients. And then the fourth part, I'd like to talk a little bit about implications for the future and where we might go when we're thinking about perinatal mental health. And then we'll have about 15 minutes for question and answer. So before I dive in, I do want to offer an acknowledgement of my work, folks who inform my work and sort of have shaped the ways that I think about it. So my work is in the lineage of critical sociology, which means that I foreground social inequities and power relations in my research. I draw heavily on abolitionist intellectuals and activists such as Dorothy Roberts, Mariam Kaba, my dear friend Zoe Samudzi. All of these folks are doing really important work to help us expand into the margins and really think about the many tendrils of the carceral state and how they influence all of our systems, including our systems of care, right? And really helping us think beyond that. I draw on organizations and people who are galvanizing us for reproductive justice, such as Sister Song, Loretta Ross, the scholar Robbie Davis Floyd. My work is informed by Indigenous and anti-colonial concepts of health, which are inclusive of the mind, body, spirit, and community. And then, of course, my clinician colleagues who are working really hard to expand notions of mental health and healthcare have a strong influence on my work as well. So I'm a sociologist and a mental health clinician, and I study how people make sense of their health and well-being. I think about how this manifests for them relationally, and I look at how they navigate systems of care in the United States. My research also critically examines how health professions are established and organized. I think about the consequences of cultural and structural reliance on the medical model and health-related stigma as it impacts and is impacted by health-related structures. And my primary motivation in my work is to contribute work for health justice, which to me means addressing power hierarchies that are embedded in these systems, disrupting norms that rely on pathology, and of course, expanding our notions and structures of care. I'm going to draw on my research throughout this talk, offering data from a 2.5-year ethnographic study that I conducted about processes of mental health integration in obstetric settings. My research includes longitudinal interviews with pregnant and postpartum people, single interviews with interdisciplinary clinicians, including nurse midwives, obstetricians, and mental health clinicians who were embedded in perinatal care settings. And I also conducted observations of a mental health team that was embedded in an obstetric organization. So my research sits at the intersection of 3 primary problems: the worsening perinatal health outcomes and inequities in the United States, the stressed state of our healthcare system, which has become increasingly challenged by the COVID pandemic, and mental health crises, which have also been worsened by COVID. In the perinatal period, specifically, mental health issues are predominant. They're among the leading causes of death in especially the postpartum period. And we'll talk about that a little bit more, but that just to underscore sort of the interconnectedness of these issues. So in this first part, my objective is really to get us situated in a shared understanding of sort of what I'm talking about or how I'm thinking about the whole person in context. I'm going to provide some context about pregnancy-related health, mental health, and then bring these things together. So we're going to begin by mapping the domains of mental health. Let's get grounded in a shared understanding of what this is, because mental health is a slippery concept and it means different things to different people. So today I'm really thinking about mental health as emotional, about our emotions, right? Our states of mind, our feelings. It's about our social context, which includes relationships and our circumstances. And it has to do with our psychology, which is about mind, behavior, and thoughts. So not only do I want to establish that mental health is constituted by all of these components, but I really want to emphasize the interconnectedness of these domains. So now let's talk about health in pregnancy and postpartum and establish a shared understanding. Some of you may already be here, but I want to make sure we're all on the same page. So the perinatal period is inherently physiological, it's relational, spiritual, and emotional. And it, of course, includes those elements of mental health that I touched on. The perinatal period is marked by emotional instability, physical changes and recovery after birth, the challenges of caring for a newborn, and it's strongly influenced by social context. So I've just pulled out a few things that come to mind sort of when we're thinking about the perinatal period, but there are many more. So bringing these things together, now we've established the lay of the land of mental health. We've talked about the perinatal experience. I want to talk about perinatal mental health and sort of how that's being animated, talked about in our society, in our contemporary society. So when people talk about perinatal mental health, it's likely you'll hear it referred to as the most common complication of childbirth. About a quarter of birthing people will be affected, but some estimates, especially in this COVID era, say up to 40% or half of people will experience a mental health issue. And this is predominantly depression or anxiety while they're pregnant or postpartum. Pregnancy and early parenthood often increase social stressors. For example, relationships and economics are often negatively impacted by pregnancy and early parenthood. And perinatal anxiety is really high in the United States. So postpartum depression has definitely worked its way into our mainstream vernacular. And I think it's the first thing that we think about or talk about when we're considering perinatal mental health. But we're increasingly talking about perinatal anxiety as a common source of suffering in pregnancy and postpartum. And of course, this is bound up with depression for some people, and these can be difficult to parse apart. But the prevalence of perinatal anxiety could also be why we're seeing these higher estimates of mental health complications, perinatal mental health complications. I want to touch briefly on some specific mental health complications in the perinatal period because these have a lot to do with the significance of this as a health-related crisis that needs our attention. So first, the perinatal period is the time over the life course when women are most likely to complete suicide. And suicide accounts for about 5% of pregnancy-related deaths. One study conducted recently found the highest occurrence to be 9 to 12 months postpartum. Some pregnant people use substances, and this can be a tricky issue for clinicians and their patients to navigate. That trickiness can be accounted for in part because of stigma associated with substance use and mental health more broadly. We have very strong negative historical portrayals of mental illness in our society, and these really are the bedrock of how we continue to think about mental health and illness. In healthcare, the separation of physical and mental health further entrenches stigma, and in the perinatal period, stigma is especially prominent because of our cultural pressures to perform pregnancy and motherhood flawlessly and joyfully. So if people's perinatal experience is different than this, it's likely they'll experience some stigma as a result. All right, so I want to touch briefly on inequities in perinatal health in the United States because these really need to inform how we address the many health-related issues, including mental health for pregnant and postpartum people. And I want to underscore right up front that many people's mental health needs are unmet in the perinatal period, and the impact of that is unequal. Black women in the US have the poorest pregnancy-related outcomes, even when adjusted for class status. There's a lot of talk right now about Black maternal mortality in particular, which on the one hand has been really important awareness raising, and on the other hand has further entrenched fear for Black birthing people. Their children are also more likely to be removed from their care, and their communities experience high rates of systemic policing. Indigenous women experience significant inequity in pregnancy-related health outcomes, and their children are 60% more likely to be removed from their care than white children. Outcomes among Mexican and African immigrants worsen with length of US residency. And very briefly, I'll touch on the work of our colleague at the Osher Center, Carolyn Ponting, whose research on Latina mental health indicates that discrimination is a bridge that binds together psychosocial stressors and depressive symptoms, which suggests that discrimination is really interwoven into all of these experiences. So it's important that we recognize here the major drivers in how society is built and operated, right? Capitalism, colonialism, racism, patriarchy, and understand that these together animate the health and healthcare experiences of people with an unequal impact. So if we think about all of that, right, you think about Black women and the threats to their autonomy, their mortality, Indigenous women and fear of involuntary intervention, Latinas and perceived discrimination, right? We can really see that this is where perinatal mental health is rooted for many people. So we've laid the groundwork here and situated people in important social context. So not only are we talking about the whole person as including physical, mental, spiritual well-being, but we're really putting them in the structural and social context of their lives. And what I want to do next is examine what we're currently doing to address perinatal mental health. Primarily, we're drawing on biomedicine and the predominant siloed system of healthcare in the US. This is our main approach to addressing perinatal mental health. So how we address pregnancy, whose territory this is to manage, is a socially constructed phenomenon, and it's incredibly unique in the United States. We outspend all countries in perinatal health care. We have among the poorest health outcomes, and we're one of the only countries in the global north that has an obstetric dominant system of care. And this system relies on and reproduces mind-body dualism. Because of that, right, and it's a system that lacks mental health parity, and this limits care. And this model is inherently hierarchical. It bestows physicians with medical authority, and it situates all others as secondary experts or support to physicians. And this negatively impacts interprofessional collaboration, which can in turn negatively impact how patients experience their care. A lot of my work is about this interprofessional collaborative piece, and I'm not talking about that today as much. And I don't bring in data from the mental health clinicians who are a part of my care, but this really is an important aspect of the situation, and brings in many puzzles for us to sort of contend with when we're talking about addressing perinatal mental health. So in my work, I draw on medicalization to understand this phenomenon. Medicalization is a theoretical accounting of how we collectively come to accept biomedicine's interpretations and treatment for human behaviors that are often seen as moral failures or legal violations, just to name a couple. Medicalization is ultimately for social order and control, and it leads to medicine having a cultural authority and power. So when it comes to the perinatal period and medicalization of this issue in the US has successfully resulted in a broad reconceptualization of pregnancy as medically problematic rather than as experientially and organically demanding. So historically, globally and in the United States, pregnancy and childbirth were supported by midwives. The context of our white supremacist and patriarchal society, combined with the period of industrialization, led to the rise of professionalization. And with that, the field of medicine became a dominant profession. At that time, new physicians successfully claimed the territory of pregnancy and childbirth, establishing a specialty field of medicine, and midwifery essentially became obsolete in the United States. At the same time, in the early 20th century, the US saw its first systematic public health campaign that further pushed pregnancy into the purview of medicine. So the US Children's Bureau published a pamphlet called Prenatal Care. It was first published in 1913 and really got a foothold by the mid-1930s when it was distributed to, by that time, it was distributed to well over 22 million people. So this pamphlet, Prenatal Care, represents the biomedical interpretation of pregnancy as it was first introduced to the public. And it really shows us the ways in which the universal claims of biomedicine can advance a particular understanding of pregnancy and childbirth. And it shows how getting the public on board with these conceptualizations is one key way medicalization processes happen. And we can see this still today, right? There's a nearly uniform accepting of perinatal care existing in the purview of obstetrics and birth happening in hospitals. So I want to talk just a little bit about obstetrics before I move back into medicalization and thinking about mental health. So obstetrics as a biomedical specialty is defined by routine screening, fetal monitoring, short appointment times, and minimal postpartum care. This model was established, as I just noted, in 1930, and aside from technological advancements, it has really not changed much since. Obstetrics and the healthcare system in which it's situated are at times criticized for their risk aversion at all costs, which advocates and scholars, they point to insurance, reimbursement mandates, healthcare system protocols, malpractice concerns, these being the primary drivers of obstetric decision-making, right, over sort of clinical need or judgment. So the form this takes then is surveillance. As anthropologist Robbie Davis Floyd explains in her definition of obstetrics, it's normalized aggressive intervention with an emphasis on short-term results, And it's motivated by an underlying fear of catastrophic outcomes and professional consequences that ensue. And so obstetrics works to keep fear at bay, giving it the illusion of control. So as I'll argue kind of moving forward, this model of care is not only inadequate for addressing the mental health of patients, it's actually having a deleterious effect on patients' mental health. So just to come back here for another minute to talk about medicalization. Mental health is also subject to medicalization, and this is rooted in the aim to socially control unruly minds and bodies. So we look across history, women, gender diverse, homosexual, people of color are routinely subject to pathologizing. And there's a history of institutionalization to hide away and otherwise manage neurodiversity throughout society. The medicalization of mental health can lead to legitimization of experience, of the illness experience, and it can facilitate important treatment developments for people. It's constantly changing, right? So this is one thing about medicalization as a process, right? Like the social constructionism is the sort of undercurrent of medicalization, right? So what is happening in our society is deeply informing what gets taken up by biomedicine. We can look at homosexuality as an example, right? This used to sit as a pathological disorder in the DSM, and it no longer does. And today we're seeing a push to include the diagnosis of postpartum depression in the DSM, right? So these things are fluid, they're always changing. And this really complicates the uptake of mental health care and biomedicine, right? This plus social stigma carries the diagnostic categories with broad symptom lists, the lack of telltale biomarkers to guide treatments. It makes mental health particularly tricky, perhaps especially in obstetrics, which relies on measurable markers of health to guide interventions in its model of care. So all this to say, mental health is subject to medicalization, but it's not easily addressed by the standardized care logics of US healthcare and biomedicine. And what I find in my research and what other folks have found is that it generates clinical uncertainty among clinicians. So considered altogether, what does this have to do with perinatal mental health? So our contemporary awareness of perinatal mental health stems from a postpartum self-help movement in the 1970s and 80s. This was a collective organizing and consciousness-raising effort that really focused on gender-based oppression and the inherent suffering of early motherhood, specifically because of the organization of society, gender divisions of labor, and persistent low governmental support. Over time, this took some twists and turns, and the movement began primarily seeking legitimacy via biomedicine. And so we can see now, we've really moved from a social movement that's looking to the social and structural aspects of the perinatal experience to a disease orientation of pathology and treatment seeking. So these are some of the ways here that is happening. And I'm really focused here today on mental health integration and perhaps especially screening in obstetrics. So this advocacy has led to increased integration of mental health in obstetrics. Today, I think over a dozen states have successfully passed legislation requiring mental health screening in prenatal or postpartum care. I've put California's state policy up here. A number of professional organizations have issued position statements encouraging screening. It's increasingly a strong cultural norm, even if legislation doesn't require it. It's routinely institutionalized in care today. And we're seeing this now move into the realm of pediatrics as well, because we lack postpartum care, and they're often the first point of contact for new parents. Okay, so these are the puzzles driving my research. I want to turn now to some of my more specific research findings and synthesize a bit of what I've learned from my research participants. So first, I want to say right up front that there are people for whom screening is productive. Some people indicate they appreciate being asked. Screening has the potential to reduce mental health stigma simply because we're talking about it. And of course, there are times that the stars align and someone screens positive, they have a productive conversation with their clinician, and they're able to be connected with appropriate resources. That's the positive intended outcome of this institutionalized procedure. I've pulled out here 4 quotes, though, that really um, uh, sort of exemplify what I found from my pregnant and postpartum participants when it comes to their experiences with screening. So this person says, I actually checked the box, the screening tool, when they gave it to me after my baby. It took a ton of courage. No one said anything to me. So if they're going to give you a survey, they should at least check in after. So this person's really touching on how like it was very hard for me to, say something, and then I did, and nothing happened, right? So here's the sort of fallout of having, not a plan. This person said I had 2 miscarriages, 0 people asked questions about my mental health. So this is really speaking to the invisibility of many perinatal health experiences and how mental health might be impacted. This person said, please fill out this survey so we can rate how much of a liability you are. Thanks. So here, this person is seeing through the system, right? And sort of touching on how distancing this feels. It's an impersonal process. And then this person lastly said, I passed the test and still had major postpartum anxiety. So, that points to the limits of the tools that we have when it comes to using screening tools. So the research doesn't show yet that screening improves perinatal mental health outcomes. And as we can see from these comments, it can have the unfortunate the unfortunate effect of alienating people. The efficacy of this practice as a pathway to care is disputed because of numerous systemic barriers, such as lack of time, lack of access to resources. Clinicians are inconsistent in administering screening tools, and there's variable patient engagement, right, which typically has to do with mental health stigma and the fear of state-based interventions. So I want to turn now to, so there we're seeing like obstetrics is trying to address mental health in the way with the tools that it has and the way that it can within this structure, right? And now I want to turn to the impact that I find obstetrics itself is having on people's mental health. So not only are folks interfacing with mental health integration in obstetrics, but it has bearing on their mental health through the care experiences they have. So I argue here, essentially, we're going to have a difficult time making gains in the realm of perinatal mental health if we don't disrupt sort of the institution and the screening that is causing people anxiety, harm, so on. So this participant, who I called Joe, told me about a 20-week ultrasound she had. She said they couldn't get a look at his face, a good look at his face. And then he had a spot on his heart, and they're concerned that those are both markers for potential Down syndrome. I remember so vividly getting the call from my doctor being like, don't freak out about what's happening here, the things you need to do. So Joan went on to reflect on the whole of her experience, and she told me, it feels like my anxiety went up and it never really subsided. So in her experience, routine prenatal testing and the resulting provisional diagnosis started this, quote, whole chain of stress and anxiety that deteriorated her mental well-being and depleted her postpartum resilience. Like Joe, Natasha told me about hearing she might have placenta previa. She said, I was shocked because it's not super common. I'm still worried if it will resolve. I can't stop thinking about far things that could happen in the future. So yeah, I'm definitely anxious and scared. So these participants were caught off guard by ultrasound results, right? They described feeling anxious, scared, and constantly preoccupied by concerns of a potential pregnancy. You can see up here, my participant, Beth, she referred to all of this as the panic of best practices. She said no other country freaks out like this, comparing the high intervention nature of US care to that of other countries. And so here we're seeing like the problematizing a normal pregnancy in these ways. It has a very powerful signaling effect, which can lead patients to conclude, I should be worried. And I'm arguing here, we can't deny the impact this itself has on people's mental health. I also found in my research many opportunities for connection were missed between clinicians and patients. Jasenia was a participant who discovered at an ultrasound that she was having a miscarriage. She said, I felt like my heart was hurting. I was upset. I started crying. I felt hopeless and like a failure. And then she told me about how the clinicians briefly explained miscarriage is common. And she said they were avoiding making me feel more upset and they quickly left the exam room. So in retrospect, she wished she'd been offered more physical touch as a gesture of support or a follow-up appointment within a day or two to help her process her loss. So knowing this from other participants, that small empathic gestures make a considerable positive impact, right? And this experience highlights a missed opportunity for clinicians to support her mental health by acknowledging the grief associated with her loss. And the last thing I'll say here is that, you know, mistreatment, physical or verbal abuse, neglected care, non-consented care, all of these are woven into the system of obstetrics, and of course have an impact on people's mental health. So on the flip side of this, my participants articulated three key things that worked for them in their care, things their clinicians were able to do to cultivate support and empowerment. They took the time to listen and convey empathy. They're open to including patients' perspective about pregnancy and childbirth preferences, and they explained important information. So this combination of key behaviors resulted in them developing trust in their clinician, who they would then describe as nurturing, caring, or personable. Natasha described what she perceived to be an effective way for her midwife to check in on her mental health. She said, every appointment, even though she's rushed for time, she pauses and says, how are you doing? Are you getting sleep? What do you need to be supported better? I get asked that at all my visits, which I think is really good. So it just goes beyond blood pressure checks and measuring the belly or whatever. It's a more friendly check-in. That's hard work, though, for clinicians who are tasked with a lot of things in a very short clinical encounter. So I'm going to shift my attention now to the birth workers who are at the front lines of all of this, because when it comes to our methods of healthcare in the perinatal period, it's not working very well for them either. So I found their efforts to implement and comply with this standardized practice of mental health screening, it generated a lot of discomfort among the obstetric clinicians. Many of them felt ill-equipped to deal with mental health issues, and they really encountered this tension between the emerging approach and multiple forces impeding their efforts. Jackie, a nurse midwife, told me that question, meaning the question about mental health, right there is like a whole visit. Obstetrician Rachel said, I don't have the bandwidth to get into that as much as I feel like it needs to be. It's one of those Pandora's box things. When you bring it up, you have to be able to follow through, and I can't do that adequately. Uniformly, the clinicians articulated that this challenge of time deficit is coupled with being, in their words, clearly underprepared by training, leaving them without strategies to practically meet the mental health needs of their patients. But this, I argue, stems from the medicalization of mental health, right? This idea that you need very specific, specialized skills to intervene on mental health. That's another thing we're supposed to have expertise in, right? So I found that because of this, obstetric clinicians were afraid of serious mental health issues they might miss, in addition to the sense of helplessness they felt when they identified a patient's mental health needs. So they really faced these dual conflicting fears. So just to recap here, right, there are these barriers, we're facing these barriers. to mental health integration in biomedicine that really hamstring efforts to address perinatal mental health in an effective way. So we don't have adequate screening tools. We lack clinic-based resources. We don't have enough community-based resources or ways to collaborate between clinics and community-based resources. And as I've talked about, there's, persistent patient and clinician fears and stigma related to mental health that get in our way. So I realize I'm poking a lot of holes in the situation we have, and this can feel daunting. So I want to make sure we get to talk about where we can go from here. So one place to go is expanding mental health care for sure. And in, some of my work, I talk about um, in clinics where they're trying to integrate mental health teams, I advocate for making those teams big, robust, right? Because they tend to, right now in the current form, they tend to be very small. They can't meet the demand, and it's unsustainable for the mental health clinicians who are trying so hard to meet the need in the clinic. So if we're going to do that, if we're going to bring mental health teams into perinatal care settings, then we need to do it at a grand scale that really reflects the need. Expanding mental health care tends to be the primary aim of perinatal mental health advocacy today. I want to spend time elevating a few other ideas that tend not to get as much airtime, and that can help us think through the many arms of change that really need to happen in order for us to address the whole person in the context for perinatal mental health. So I'm thinking about the interplay of structural change and influence, systemic change and influence, and then what can happen specifically for clinicians at the individual level, right? So I'm putting a bunch of things up here to sort of make a point that um, mental health doesn't happen in a vacuum, right? I'm going to say that again, probably, and again and again. But I'll just touch on a couple of these, right? Specifically, paid family leave, universal basic income, and accessible, high quality childcare, right? So these are things that we lack in our society, and they have major bearing on perinatal mental health. If we don't structurally address our devaluing of care in this country, we are not going to be supporting people's mental health in the perinatal period. So these are all things that have upstream influence on perinatal mental health. We should absolutely be advocating here as fervently as we're advocating for more mental health care. So at the systemic level, I'm thinking about systems, I'm thinking about our professions, our places of work, the communities where we live. So how can we make change here? I think one of the big things is resisting conformity to the medical model, and this can look a lot of ways. For one thing, we can amplify the midwifery model as more whole person oriented. We can get grounded in this model of care for clinicians working as midwives in obstetrics. Even though they're situated in the obstetric setting, how can they really stretch clinic-wide, right? The influence of the midwifery model. How can this philosophy of care support a different approach to mental health? Expanding and diversifying the workforce, who's providing which type of care, right? So again, we talked about the fact that our design, or the perinatal healthcare design in the United States is obstetric dominant, is unique. This is not the norm, right? So the norm, right, exists all over the world, right? That the organization of practice looks like midwives managing the vast majority of pregnancies and supporting people through the perinatal period. So how can we think about, systemically and probably structurally as well, changing the organization of practice? Group care. I think that we need to be doing more group care. If people aren't providing group-based care in their practice, they should be finding ways to do so. There's good evidence behind group-based care. All the people in this room are contributing to that data. It offers a lot more time in the clinical encounter. It builds peer support, and there's evidence that it's protective of people's mental health. We need to develop new postpartum care norms. We don't have really any model of postpartum care. So this is beginning to shift within biomedicine, right? Professional organizations have come out to say, like, we should be doing more here. The community midwifery model is an example of pretty robust postpartum care, at least acutely. It ends pretty early in the postpartum period, but it starts immediately postpartum. So I think, so we certainly need postpartum care. And as I mentioned earlier on, most mental health issues pop up in the postpartum period, and the highest risk periods tend to be around 6 months, 6 to 12 months postpartum. So thinking about the way we design postpartum care is important. I don't know that we should be looking to biomedicine to solve this problem, to be the answer. I'm sure biomedicine has a role, but we need to be really thoughtful, critical, and careful about how we're drawing on biomedicine and putting our resources potentially in more community-rooted, home-based, interdisciplinary ways of supporting this time. And then let's talk about the individual level. So I'm speaking to clinicians here. I'm very clear that fear for clinicians is structurally motivated, and clinicians face consequences when things go wrong. And at the same time, I want to draw on clinicians' agency and help them begin to think about where they can expand their capacity to face fears without leaning so heavily on the institutionalization of risk. So how are we addressing fear about perinatal and mental health? What are the worst case scenarios that are driving our decisions? Who are you in community with that can help hold the bigness of this work so that we can move in it without being hamstrung by fear? Clinicians need to interrogate their commitment to systems of family policing in the form of mandated reporting. I also want clinicians to consider how to use their power for believing and supporting patients in their quest for space and time, such as in the case of advocating for long-term disability. I say to clinicians a lot, you can choose to just believe your parents and, your patients. And even bigger than that, you can believe that all people deserve rest and spaciousness, and perhaps especially during and after pregnancy. Because we have no structural support for this nationwide, I implore clinicians to think of themselves as radical supporters rather than gatekeepers in this regard. In mental health care, we emphasize the clinical relationship as the center point of successful healthcare experience. And so I really encourage folks providing perinatal care to elevate this aspect of the care they're providing. And importantly, crucially, to think about how this directly impacts the mental well-being of your patients, right? So in other words, is this interventional for mental health? What my participants told me has substantial bearing on their well-being through pregnancy and beyond is how they were treated by their clinicians, right? So they specifically underscored being invited into decision-making, feeling understood and aligned, and being directly asked about their mental health. So what are the small ways clinicians are already doing this and can continue to do this and consider this interventional for patients' mental health, right? So I think the last thing to say here maybe is consider, the preciousness of this work of being present for some of the most monumental life experiences people have, right? What does it mean to bear witness here? Consider who you are to your patient and what this relationship is. So just to wrap up, I'll just say a couple final things. Again, I told you I would say this again. We can't think about mental health as a siloed aspect of the human experience. Doing this only serves to further entrench stigma and inequalities. Instead, we have to embrace that mental health stems from an immeasurable amount of things that are embedded in our structures, our systems, our relationships, and our individual psyches. And so the work here, I think, is disrupting our underlying assumptions about the psychosocial aspects of the perinatal experience. It asks us to challenge mental physical health dualism that has very unfortunately shaped how we think about health and well-being. I want us to allow ourselves and each other to be creative here, to be radical and boundaryless in imagining a new way forward, so that this way forward together is equitable, is supportive of clinicians, and really works to improve outcomes so all people can thrive. So thank you so much for listening to that. There's my contact information. I am going to stop sharing my screen. So I'm happy to provide that later, but I invite your questions. Feel free to put them in the chat or just pop in. Thanks, Carolyn. I'm so happy you're here.
I have a kind of basic question. Listening to your presentation was making me realize that I imagine that I know what screening usually looks like, but maybe I don't. And so I'm curious, are most places that are doing screening standardly screening only for depression and doing it in an office visit, or is there some variety in what screening looks like in different institutions?
There's definitely a variety of what it looks like. Uh, there's the recommendation, there's the legislative requirement, right? There's some organizational emphases and tools, like some people have like a well-being assessment that they use that encompasses mental health and includes the Edinburgh postnatal depression screening tool. Um, but how clinicians actually implement it in the room is idiosyncratic. It really is variable. And I think that's part of the challenge here, right? But yes, so the short answer is the Edinburgh tool is the one that is pretty common and used most of the time. Heather.
So that means that
Oh,
anxiety is not something people are screening for,
there is an
right?
anxiety. Yeah, there is one anxiety screening tool, but it's not used very commonly. Mhm. Heather would love to hear any thoughts regarding folks that don't identify as women struggling with perinatal mental health. Um, this is a great question. I don't know that I have a lot to say about this necessarily. It wasn't something that came up in my research and my data. But I will say that when we think about the challenges of gender diverse folks, people who are non-binary or trans who are experiencing pregnancy and this system of care, right? I think we could make some assumptions that it's going to be uniquely challenging and thus stressful, right, on their whole experience, including their mental health. I wish I had more to say about that, but yeah, thank you for that question.
This is Maggie,
Hi,
and
Maggie.
hi there. To maybe part of the point of your talk, you might hear a 5-month-old in the
Baby.
background. So I apologize if that is
Welcome.
distracting. Thank you. I really appreciated your talk, not only because of where I am in life, but I was wondering about your thoughts, and maybe this gets into the interprofessional data and insight that you have. If it matters who does the screening, and if there's any data from your work or otherwise about whether it's protective for the clinician to do the screening, for someone who was not involved necessarily in like labor and delivery at all to do the screening. I in my experience, that really mattered. Not for the best. And I'm just wondering about the insights you had about screening being something, yeah, that is this potentially harmful time.
It's tricky because I heard all different things from patients about how screening worked for them. So some people appreciate the distance, right? Where they can, be given a form and check some boxes and don't have to be asked directly. It felt less stressful for them. But I would say most people told me, nah, screening tool it's not super helpful. I kind of know how to, make it say what I want, kind of manipulate the tool, right? And then a lot of folks talked about, like, I just wanted my care provider to just like have a conversation with me and just ask me like that, the one quote I shared with you, like, how are you doing, right? To sort of humanize this interaction and feel more connected in it. So there's a range. And I think maybe the thing I would say that makes the biggest difference, if people are being screened with the tool, what happens afterward, right? So if they're screened, do they then have a meaningful conversation with someone who has the power to do something with that information, right? To get them the kind of care that they really want? Is it effective, in other words, right? Let's see, Dorothy, thinking about how hard institutional changes can be. What do you think about other perinatal providers or ground-up community-based approaches to combating the challenges you discussed to perinatal mental health? I mean, I do think a big one could be, if we're going to invest in integrated teams, I think making them big integrated teams, right? And it's really hard for me to think about, like, how do we expand care without addressing the payer system as a primary holder of power here, right? Like, people ask this question a lot, like, what can we do with what we have? Well, we can do a little, but I really don't see how we can do that much without significantly changing, the way mental health care is being reimbursed and getting through the quagmire of these clinicians having to deal with multiple payer systems. And it's just so burdensome for the mental health teams, right? They're already sort of overworked and under-resourced, and then under-reimbursed, and they're having to deal with all these different payer systems. And that was like the number one thing that made these programs really unsustainable in the perinatal setting. So I think in an ideal world, we would build really robust systems that are, successfully embedded in perinatal care. But how they're reimbursed, how they're supported financially really needs to change. So that's one thing. And then, of course, I think community-based care, right? Like drawing on community midwifery, finding ways to make this more sustainable, using group-based care. Home-based care is a little, in the United States, it's a little tricky. There are some issues, when we think about the influence of the carceral state and having people come in people's homes, it doesn't always feel safe. So I think in an ideal world, that could be a great solution, but it doesn't work for everyone. So yeah, thank you for that question. I think because of the design of our healthcare system is very challenging.
Jessica, thanks so much for that talk. I'm super curious if participants spoke to you at all about ways that they were managing different manifestations of distress, sort of in the context of what maybe didn't feel like a supportive perinatal experience. Did people talk about the use of community, family, spirituality. Like, was there any of that that came up in the interviews?
Do you mean specifically perinatal healthcare experiences, or just broadly they're struggling in the perinatal period?
I guess thinking about folks who might have shared with you that they were having some sort of distressing situation and it wasn't responded to in a way that felt appropriate in the perinatal care space, if they talked about things that did work for them.
Yeah. So a lot of people talked about if they had access, they had like, private therapists who were in the community, kind of separate from the system, talked about friends, drawing on friends, partners a lot, family members. But there were a number of participants who had gotten connected to one of the mental health clinicians in the clinic, and those folks tended to have an extremely positive experience. So it improved access for some people, right? Even though they were not able to meet, a fraction of the demand, but for the folks who were able to get into one of the co-located mental health clinicians, they spoke very positively about that experience. Yeah. Maybe one last question. There is one. San Francisco funds family resource centers and requires them to provide services to pregnant. I don't know anything about this. So my disclosure is that I live in the state of Oregon, and my research was based in Oregon. So I have a lot more context up here than I do in California. But yes, I think formalizing some of these systems, right? But I think you're getting to this, like, how do we smooth the pathways between the current obstetric model of care that we have toward more community-based, right? Like de-silo these things somehow, I think could be hugely beneficial to getting people care, for sure. Yeah. Thank you all so much. This is really fun to talk with you. Appreciate
Thank
it.
you so much, Jessica.
Thanks.
Everyone, feel free to come on screen for a minute if you want to. And Virka, do you mind putting up that slide again for our next presentation? If you're
Yeah.
here because you're interested in perinatal care, maternal infant health, etc., our next research seminar is also going to be somewhat related on February 27th at noon Pacific, also on Zoom, with Liliana Lengua, who's at University of Washington. So feel free to join us and spread the word to other people at UCSF in San Francisco and beyond who might be interested. Thanks, everybody. Have a
Thank
great
you.
day.
Thanks.